Hello, Houston. We had just finished last time talking about some of the lead-in problems when we try to define psychopathological or abnormal behavior in various ways. I thought I'd put that class of disorders into a broader context for you this morning as we start today, as we start the lecture, and just talk to you a little bit about the statistics on mental illness and its prevalence. And in essence, the leading sources of disease across our society basically break out, as you can see here. Number one is ischemic heart disease of various types. But look at number two, unipolar major depression. I'll come back and talk about what we mean by unipolar a little bit later. But major depression is one of the major sources of illness in our society. Falling off then, cardiovascular illness is down to 5%, but 6.8, almost 7% of the disorders in our society relate in one way or another to depression in one form. We'll come back and put that in a broader context here in a little bit. But if you look at the burden of various disease classes, what they weigh in on for society, number one is cardiovascular conditions. Okay, 18.6% of the total illness that we have. Behind that is mental illness, including suicide, which in some cases is kind of a separable incident, but generally related. Number three is malignant diseases, specifically like cancer. And if you notice, beyond that, everything else occurs less than a third as frequently as those three major causes. So mental illness in general is well up there in terms of causing us problems in our everyday society. And if we look at specific mental disorders, break out that particular category, then what we find is the following kind of division. Again, we're right back up there with unipolar major depression as the number one cause, as you'd expect. About a third as frequently, we have difficulties with schizophrenia, which is a more serious disorder, but is by no means as frequently experienced in the population as a whole. And from there on, we're down to probably 20% as frequently occurring illnesses as things like major depression. So even something like bipolar disorder and obsessive compulsive disorders, two that we'll be talking about here today, only occur in about 1.5 to 1.7% of all cases. And that's just, remember, in the 15 or 16% of all of us that end up experiencing mental disorders in any kind, of any kind. Well, as you can see at the bottom of the figure, there is 15.4%. That data is drawn from the last time the National Institutes of Mental Health did a survey, and that was back in 2001. So the data is a little bit dated, but reasonably stable, because if you look at the one done 10 years earlier, the figures are very close to similar. So we're talking about a stable set of illnesses and how they impact us. And when we look at the one other way to show you what's involved here is to suggest that the peak year for mental disorder was in 1954, which may surprise you as to why that was such an onerous year. I remember it. It was a heck of a year. But we got through it collectively. But there's a reason for that. And that is if you plot here, what you're seeing here is patients in state and county mental hospitals, and you'll notice that 1955, which is the closest year to 54, which was actually tallied, you can see that there is a peak at that point, and then it starts dropping off, and dropping off pretty rapidly, because between 1955 and 26 years later, 1981, the number of patients in thousands in a mental hospital has dropped by about 80%, and there's a reason for that, as I'll show you here in a minute. But it has to do with the number one factor. Think about it a minute. What was going on in the mid 1950s? Because it was one of those events which actually led to this significant decrease in mental health patients, and that is very simply the invention of tranquilizers. Tranquilizers were first introduced in 1954. And in fact, what we've also done, of course, is to develop many more treatment options. Our sophistication with things like behavioral therapy has increased substantially in the intervening years. And we've also we're offering, 50 years after that peak, many more effective care circumstances in our hospitals in general. So that the peak year, as I said, was 1954. And let me put in one other set of statistics here that are really relevant, and that is the green curves reflect the actual U.S. population. And so as you can see, what's happening is that drop in the red curves, that is the decline in the number of people in mental hospitals as a function of the entire population, really is in contrast to the growing size of the population itself. So the percentage basis is even more impressive. The drop on a percentage basis of number of people hospitalized for mental disorder has been stellar, has been staggeringly large, based on essentially things like tranquilizer. And if you think about it just for a minute statistically, there's a good reason for it. And that is that, as I showed you the other day in defining abnormality, we use the normal distribution as one kind of sample of what we could talk about. And if you think about a tranquilizer, well, let's even do it the other way. In your head, think about normal distribution of human population or behavior where the midpoint is acceptable. I mean, that's what the majority do, so it's got to be acceptable. Even if we're all crazy, it's still got to be acceptable. So at some point, you draw a line out here somewhere that says, okay, anything more extreme than that on that tail is abnormal, hospitalizable. And in 1955, we had a substantial proportion, a significant percentage of our population hospitalized at that point. The immediate effect of tranquilizer was to move that line about 2 standard deviations further out on that distribution of whatever behavior you're trying to plot. And so the effect was, if you think, the reason the effect has been so staggering in the curve that I was showing you a minute ago is that we go from this point, whatever the cutoff point was, into the tail of the distribution, and by moving it 2 standard deviations further out, we've knocked out about 80 or 85% of the cases that would have been hospitalized. And thus, when tranquilizers were introduced and their impact were really beginning to be realized, that drop in number of patients was predicted. And we've pretty much hit it on target. It's followed kind of the normal laws of statistics or the laws of statistics in a normal distribution. And so it was simply the fact that cut line with tranquilizers could be moved about 2 standard deviations further out, meaning that the vast majority of people who were acting up for whatever reason can now be controlled by tranquilizers, and it's much better for any of us to be at home when we have such a problem than to be in a hospital. And that's the statistics and tranquilizers are the 2 major reasons why we've had this very impressive change in what we're talking about. Now, if we get in and look specifically at the disorders I'm going to be talking about here today, the main book that is utilized here is a manual with a very impressive title, the Diagnostic and Statistical Manual of Mental Disorders, which is a real mouthful. So instead of saying all that, what we simply do is to say DSM. And that the original basis for providing diagnostic labels for mental disorders was proposed by Freud. And he actually developed a system that emphasized the causative events, what causes particular kinds of disorders. That was replaced, however, by the work of Emil Kraepelin in 1909, who essentially came up with the idea that instead what he wanted to propose was a categorization system which was essentially descriptive. It was a broad descriptive system of various kinds of behavioral disorders, and it was devised by Emil Kraepelin in 1909. So that was one of the few battles in early personality joustings that Freud lost. He came up with a proposal, and it simply was not adopted by the community as a whole. They went with Kraepelin's system instead. And so the net result was the Diagnostic and Statistical Manual of Mental Disorders, which has come out in a variety of different forms. The first one was published in 1952, followed 16 years later by the DSM-2. Here's a picture of what the DSM-2 looks like. You can't really see it in good order. I should have been off to the side a little more when I took that, but the shadows kind of hint at the fact that that's a manual that's spiral bound, and it's maybe 100, 120 pages thick. And that was a growth from the previous one. I have envisioned that. I've never seen the first DSM, but I kind of envision it as a ragged-edged, stapled collection of type descriptions. I don't know that it was that goofy, but in fact that's what DSM-2 looks like. It was followed in fairly quick order by several others, and that is the DSM-3 in 1980, where the system really began to assume some body and substance was in what came to be known as DSM-3 revised, also called the DSM-3R. And by that point in 1987, as you can see, the book is substantial. It's jumped to about 450, 500 pages, and it's front and back cover. With various kinds of details, and it follows a system that I'll talk about here in a couple of minutes. But that's when, between 3 and 3R is when the DSM really arrived as a kind of a feature in everyday diagnostic society. And it has been followed, as you may know, by 2 other books, DSM-4 shortly later, and then equal interval after that, DSM-4-TR, which is the one that is still being actively used in the late 2000s decade, I should say. It is anticipated at the moment that DSM-5 will arrive in 2013. That's the projected publication date, but the American Psychiatric Association, who's responsible for it, has it in committee right now, and the tentative report has been released. So the proposed document is up for revision and public comment and so forth. But of course, you know, psychologists being psychologists, it probably won't be out by 2013. That's an even money bet at this point. But we'll see. It is projected at about that point. Now, the classification system that is used in the DSMs basically has 10 major groups of disorders, which I'll come back and talk about a little bit later here. But we assume that within any one group, when we categorize a given set of disorders together in one of those groups, we presume that there's a similarity among the disorders that are in that, or the disabilities that are categorized within there, including the presenting symptoms, that is, what somebody is showing you and why you're categorizing them in a particular way. Secondly, the prospects for success in therapy. That is, if you put 2 people in a similar category, the projection is that the therapies that are applied in that situation will have generally similar effects across the different types of disorders represented in there, or the people with types of disorders. And thirdly, the treatment that will be offered in a particular general disorder category will tend to be quite similar. Now, if we look at that, look at that as a general statement of the groups of disorders that are involved, we can also then talk about the ways in which the system diagnoses disorders. That is, the DSM-4-TR uses a system of the following kind. For any disorder that's cited, there is, first of all, a particular label as to what general category it's involved in, what clinical disorder is reflected. Secondly, there will be a specific diagnostic category, such as personality disorder or something like mental retardation. Those are examples of second-level categories of disorder being applied here. Thirdly, there will be a general inclusion of the general medical conditions of the person who is being impacted, because in some cases we know that behavioral abnormalities come directly out of medical causes without any behavioral or psychological basis for it anyway, at all. And so general medical conditions are included in the diagnosis. There generally will be a summary, not generally, there is a summary of psychosocial and environmental problems and how those may be impacting the person as a whole. And finally then, the system globally steps forth with an assessment of the ultimate success of the therapy. There'll be a number between 1 and 100 signed for the likelihood of moving from you are disordered, here's the problem, all the way to we've fixed it, you're ready to be put back on the streets. And so those are the 5 categories that are utilized or axes, I should say, in describing a particular disorder. This in turn leads then from groups of disorders into specific categories of disorders. And in that case, there are 4 broad categories where I'm sweeping together several different elements of the 17 that I'll mention for you here in a minute. And that is essentially, first, number 1 is disorders that usually arise during childhood or adolescence. That will include things like mental retardation that we were talking about before, or even special problems such as, for instance, early infantile autism. We're not going to cover that in our discussion today, but that's one of the elements that would be categorized among disorders that usually arise during childhood or adolescence. Secondly, we have organic mental disorders. These typically involve gross destruction of brain tissue or malfunctioning of brain tissue in a patient. Thirdly, we have what are called substance use disorders. This is a popular category these days. That would include disorders brought about by or identified by drug abuse or alcohol abuse. Again, we're not going to cover those specifically because we have very good drug courses through the College of Pharmacy that deal with a lot of the upset caused by misapplication of drugs and so forth. And the final general category that we will spend a lot of time in are the psychological or sociocultural disorders. In these cases, there's no known brain pathology as the primary causative factor, but this would include things like anxiety, psychophysiological disorders, psychosexual and personality disorders. It would also include what I'm going to call, in quotes, the functional psychoses. That would include things like, and we're going to come back and go through these in detail, but the major affective disorders, things like schizophrenia, and more likely that certain types of brain dysfunction are sometimes involved here as causative factors in the group that we're talking about there. But because of our rather severe limitations of time, what we're going to do is to focus our time looking only at two types of disorders: the most prevalent neuroses, that is the anxiety-based disorders, and psychoses, including schizophrenia and mood disorders. So if we jump first of all into looking at an anxiety-based disorders, summarizing what I was saying, there are 5 axes that we use for treatment purposes, and then there are 17 or 18 categories. And when I lay those out for you, it looks like this. And again, we're not gonna treat at all the things that are in yellow here in the list that I'm going to show you. But this is simply the full list of the 18 clinical disorders, 17 or 18 clinical disorders that can be diagnosed here. Schizophrenia and other psychotic disorders, I should say, and mood disorders are among the group we're going to look at. We're going to look at all of these: anxiety disorders, somatoform, and so forth. I would point out here, I'll come back and comment on this, but all of these used to be Category 2 disorders. That is, what they used to do was isolate neurosis as a major form of disorder, a type 1 or level 1 category disorder. And these were then Category 2 definitions of various forms of neurotic disorder. And for a variety of reasons we'll get into a little bit, the psychiatrists simply decided to do away with neurosis. And what they did then was simply move all these 5 categories from stage 2 to stage 1. They just moved them left, one category. And so we went from it isn't that our society's gotten more mentally ill, it's just that we're defining it in a different way. And so we'll come back and talk about these a little bit later. Also involve eating disorders, sleep disorders, impulse control, and so forth. You can read the whole list there, not any problem. And we won't cover those or the personality disorders. In any given list, we always throw in a catch-all category. If we can't get you in any other way with a disorder, we'll simply call you an other. Okay, so there is a kind of a random catch-all category. That one has been a little bit controversial, but it is there, so we have to acknowledge that. And in any case then, if we look specifically at the anxiety-based disorders and neuroses, we can basically define what used to be called a neurosis as simply a personality disorder that is defined by anxiety and interference with normal functioning, in which the individual basically has difficulty dealing with reality in a classic, what used to be called neurotic form of disorder. The key elements are really what we need to focus on here, and in fact those involve 3 things. One is feelings of anxiety and inadequacy. It's especially likely to show up in someone who's got this disorder under stress. And that's true of many abnormal patterns of behavior, but particularly true of that in what is the broader category that is called the neurotic disorders, now typically called anxiety-based disorders, as I'll talk about here in a minute. A second thing that tends to occur, key elements in this class of disorders, is avoidance. Rather than dealing with the source of stress, what individuals tend to do is to escape or avoid the situations. That's the way they deal with it. Doesn't solve the problem other than the immediate difficulty that they happen to be facing in this particular situation. And in fact, the third general category is the self-centered, self-defeating behaviors that tend to occur in this particular situation. It's driven from the idea that the world is hostile, person's resulting behavior is defensive, it's rigid, and as it turns out, it's rarely appropriate for the situation in which it's exhibited. The result is a kind of an interesting problem, and that is that if someone experiences stress, what this will do is to precipitate anxiety. That is, when they first realize they're in a whatever kind of a situation causes them stress, they tend to sense and create in themselves anxiety. They feel it, which in turn leads to the avoidance behavior, which we talked about as being inappropriate. But the effect of that avoidance behavior is to essentially make the person feel okay. We've handled the problem. And so the result is that engaging in that avoidance behavior ignores the problem. It gets away from it rather than actually treating it. And so the result is the reinforcement encourages the fact that the next time a stress is felt, what it tends to do is generate, again, anxiety, which leads to avoidance. And what you've got is essentially this kind of a situation. And what that is often referred to as by clinicians is simply a vicious circle. And it just goes around and around and around because it is essentially self-maintaining. It's one of the best examples in all of psychology of a self-maintaining behavior. The reinforcement is so good if you can defeat the anxiety by simply getting out of the situation, that it's easier to get out of the situation than deal with the problems you're having in the situation. And the net result is we have a vicious circle. Now, quite clearly, in terms of the theories of personality that we developed in a couple of the previous lectures, we could analyze anxiety and the resulting neuroses from many different perspectives. We could look at trait theory or the psychodynamic psychoanalytic theories that we discussed. We could look at social learning theories. And in fact, we could even look at the existential theories, which directly would focus attention directly on an individual's perception of his or her world. But in the interest of time, again, what I'm going to do is limit our discussion only to a review of the psychoanalytic perspective in this particular situation. So if we look at the psychoanalytic view, what we're talking about is a variety of different ways in which it treats anxiety. That is, anxiety shows up as a pattern of symptoms indicating the presence of a disorder. And why does it occur? Well, it occurs in several different ways, and that is that the symptoms indicating a disorder and the attempts to control it are basically generated out of a couple of different situations. One of these is simply that when we talk about anxiety, we're talking about specifically anxiety itself rather than fear. The point being that with fear, there is a particular object you are afraid of and you can name something. But when you feel anxious, you may not necessarily be capable of identifying what it is that's making you anxious. Unless with experience you gradually know what kind of situation will cause it. But we're dealing here with anxiety, not fear. Secondly, when we look at anxiety, any of us may feel that. And in any given semester, when you approach final exams, all of us get a little anxious. As a faculty member, I have to produce the final exam, and as a student, you have to go through the final exams. We're kind of locked into that exchange between us, but it's a point of higher anxiety for all of us in one way or another. I to make sure that I'm measuring accurately and assigning grades accurately, and you to make sure that you're performing as well as your parents expect you to, or you as the bill payer, whichever. But it is a source of anxiety. There's heightened anxiety. It's not abnormal. I mean, it's a normal kind of anxiety. One advantage of it is, of course, that once we pass through final exams, there is then relaxation. The quick trip to Mexico, the beach scene, all of the things that follow from the reduced anxiety in that situation. And then thirdly, so that what we're dealing with, I should back up and say that what we're dealing with in this kind of anxiety is pathological anxiety. That is where it actively hinders somebody's ongoing lifestyle. And thirdly then, when we talk about anxiety as a state, that's a momentary situation caused, for instance, by things like final exams, as we were just talking about a minute ago. On the other hand, if you have a trait of anxiety where it was with you before, it's with you now, and some representation of it is going to be with you into the future, then what you're experiencing really is anxiety as a trait. And that's what we're really focused on in this situation. So we're dealing with anxiety that is pathological and trait-like in its characteristics in this situation. And so if we look then at the psychoanalytic view, anxiety is going to show up as a pattern of symptoms that indicate a disorder and our various attempts, effective or not, to control it or to alleviate it. The question then is, why does it occur? What's the source of this anxiety? And Freud is rich with suggestions. But I would cite specifically the structure of personality as he envisions it, and that is that the id, basically as one of three major elements of the personality as Freud envisions it, is a psychological component, and it's also subject to irrational demands. If you remember Freud's description of the id is kind of, I want what I want when I want it. It's entirely about the business of serving the individual, no consideration for the demands it may put or you may put on anybody else. Those are id-based demands. They're irrational, but they're there. We need food, we need water, warmth, and so forth and so on. The id is charged with the responsibility for finding that. The second element, of course, is the superego, structurally, which is idealistic. It makes equally irrational demands. I mean, you go to school with a nice lunch in third grade, and if you're id-dominated, you're going to be grabbing other people's food in addition so that you get a nice, big, fat, luscious meal like Mom really should have made for you. And on the other hand, if you're superego-dominated, you're going to give your lunch away to other kids. And so the demands of the superego are just as irrational, and the model then suggests that the ego is really what ends up controlling both. What it's trying to do is balance off the irrational demands of the id headed in one direction against the equally irrational demands of the superego headed off in a completely opposite direction. And so what the ego does is operate to control anxiety, to maintain good self-image, and to help you survive as an individual. But fear and anxiety are essentially preconscious or unconscious, and thus you can't detect them when they're present. When the id and the superego start acting up too much, the ego, basically, according to this model, generates defensive patterns, and in fact they're labeled as defense mechanisms. And if we look at them, they really are the first line of defense. They operate, according to Freud, in all of us to varying degree. And as a result, they are adaptive. That is, the whole purpose of his envisionment of the defense mechanism is to keep you and I happy, or at least functioning in a situation. And so the net result is whoops, I borrowed the word symptoms from an earlier thing up there, and I forgot to change it back in the thing here. So put back the word, we'll go back so you can make sure you see what's there. It's adaptive. That's the word that should be there. And the second feature is that they operate unconsciously. You're simply not aware of them operating in most cases. Simmons, way back in 1946, some 70 years ago now, actually produced one of the best organizational schemes to kind of categorize all the different forms in which defense mechanisms can come. And he proposed a model like this one, in which he developed 4 general categories of defense mechanisms, which is the way I'll describe them for you, where the major features in one case are repression, and you can read the 4 categories there, but that's the way he's clustered them. Those are the strategies that they use in operating to defend you in that situation. And in essence, what he's arguing is that repression doesn't have any specific subsets, because he's arguing essentially that repression is key to all of the different forms of defense mechanisms that we can talk about, all the different styles in which the defense mechanisms can operate. And so the net result is that repression is really, it prevents expression of an impulse and therefore produces that feeling of well-being, but it's based simply on repression. It's unconscious, so you're simply not aware of the operation, the repressive nature of the defense mechanisms. You can't identify the source, and therefore you continue to feel the discomfort, and you may inadvertently expose yourself to the original source of the stress. That is, because it's operating unconsciously, yes, in one sense it's defending you, but in the other case, if it is operating unconsciously, you're not consciously aware of the source of the stress that you're operating with, and you may in fact unconsciously re-expose yourself to exactly that source. If Mom, don't want to pick on her, happens to be the major source of difficulty for you, given the family situation, you may be re-exposed to her over and over and over again, and ultimately that doesn't, until you and she can get things straightened out between you, you're simply unconsciously re-exposing yourself to what turns out to be exactly what's making your life so miserable in that situation. I don't mean to pick on Mom, but just as an illustration of what's going on in that situation. And so basically, To get away from this, it is at best a partial and at worst an inappropriate solution if you simply remove yourself from a given environment. So the second general category then involves those defense mechanisms that involve escape or flight in one way or another. Amnesia, for instance, in this case is psychological, not organic, as I'm talking about it here. And it results in simply an inability to remember past experiences in a given situation. There was an example of amnesia a number of years ago. Gosh, it's probably been 40 years ago now that I remember hearing this on the radio. But an Oklahoma radio announcer had apparently had a very awkward marriage. He didn't perceive it to be a happy situation. And the net result was that he simply disappeared one day. He was gone from Omaha, and there was a search and so forth. And he was not discovered until he was recognized by a friend from Ohio as the long-lost husband of a very troubled marriage when they happened to meet in Chicago, is where the baseball game that had happened was. But here was a guy that from Omaha had simply fled. He'd repressed the idea that he had a child, a wife, and so forth. He simply left. And he was, as a radio announcer, he was earning a livelihood in Chicago. And the net result was that he ended up being recognized by a friend from Ohio, and ultimately the ruse fell apart because of that. But he had been totally unaware of it and denied it actively when he was accused in that situation. That's amnesia. Another I've just talked about is denial, and that is where you simply reject intolerable reality in a given situation. We can think of the escapism of somebody like Walter Mitty, or our tendency to daydream in certain situations. That's a form of denial, essentially. A third is phobias. These are inappropriately excessive fears of an object or a situation, and there are many different examples that can be cited. A classic one, of course, is claustrophobia, where you have a real intense fear, anxiety, about being closed into a given situation, whether it's an elevator or a closet or anything where the walls are kind of tight in a given situation. It's also related, the symptomatology is very similarly related when you have what's called acrophobia, which is essentially a fear of height as opposed to a fear of enclosed spaces. Another one that's quite fascinating is what's called agoraphobia. And what agoraphobia involves is a fear of crossing or being in large open spaces. A classroom like this, which is pretty open and free-moving, even when we do have students here. This is a day before vacation, so it's not well attended today. But in any case, agoraphobia, an agoraphobic would have trouble coming into this kind of a classroom, simply because, you know, even though, yeah, any of us can walk in or walk out, as students are doing all the time when I'm lecturing, an agoraphobic would have a lot of trouble recognizing that freedom is his or hers to enjoy. They feel a phobic reaction to this kind of a situation. There was a fascinating article in the old Houston Post back in the early 1980s that listed hundreds of phobias that had been drawn from work done at the University of Chicago. My favorite on that list was phobophobia, which is a fear of fears. So phobias can strike you in many different ways. And in turn then, regression is another form, and that is simply where we tend to defensively revert to behavior that was typical of childhood, or simply any threat to security results in fighting, as that's a kind of a childlike response, but it would represent a regressive response in terms of what we're discussing here. The third general group then are those that involve disguise of one form or another, and there are a lot of different ways in which we can do that. Displacement is simply where we identify an alternate source as the real source of the anxiety in a given situation. Dreams is one way in which we can realign things, or the cartoon that I found that illustrates it quite well is here, where the man in the picture has had a bad day at the office because the boss has been yelling at him, "Bad job, Jenkins." He goes home and yells at the wife, "Bad supper, Nan." The wife in turn yells at the kid, "Bad boy, Rodney." And Rodney goes out and kicks the dog. So the dog is kicked because Jenkins had a bad day at the office. And in each case, what's happened there is that the person, rather than standing up and correcting the situation where it occurs, which is where it should have stopped, in each case simply displaces it to the next weaker man or woman in the social hierarchy there. That's an example of displacement. Other forms involve things like identifications, where you assimilate the features of another loved one or something like that. I think I talked once before about a very good friend of mine whose daughter simply became a clone of her favorite rock star when she was 11 or 12 years of age. Rather than going through the difficulties of figuring out who she was and developing a personality based on it, she simply adopted wholesale the clothing style and everything else of her favorite rock star. She ended up as a very successful young lady, but it was just kind of interesting that at 12 she was her reaction to growing up was a defensive one. She simply became a rock star by clothing and activity and so forth and so on. Projection is where you attribute undesirable features of yourself to others. And in that case, that one's kind of tricky, but if you don't like somebody, what you do is to make it appear in your own head as if they don't like you, and therefore it's okay for you not to like them in that situation. That is essentially one form of one benefit that, in quotes, that identification will give for you. And rationalization is where you substitute a good reason for some other behavior to disguise a bad reason from yourself and others. You know, you get stopped for speeding, and the classic response is something like, "But officer, my wife's pregnant." So you're just trying to justify without acknowledging, yeah, in fact, you were lead-footed going through I mean, it's not good to be doing 71 in a school zone during the day, okay? Another major group are those that involve modifying the source of the difficulty that you're experiencing. This would include things like compensation, where you make up for deficits in one area by overachieving in another one. One of the classic examples, and this has generated some controversy, but one of the classic examples that's often cited of this is Gypsy Rose Lee's mother. In the classic story of Gypsy, some have argued that basically it was really a personality disorder on the part of the mother, who insisted on moving her daughter, guiding her daughter into a Broadway career that basically involved taking off a lot of her clothes or dancing around in relatively minimal dress. And it was widely thought that really what was involved there was the reaction formation of the mother, that she was getting back at society for the difficulties that she herself was experiencing. If you hate the boss, you go out of your way to be courteous and smile to that person, simply to cover the fact that you really have very intense negative feelings about them. And sublimation is where you express unacceptable impulses in socially acceptable manners. So if you have a real strong urge for destruction, what you'll do instead is guide yourself into a career where you're a surgeon, so you get to destroy things legally. I'll leave you to ponder that, but the next person who operates on you is actually neurotic, but not suggesting that's true, but it would be one example. So we summarize this by saying essentially that what the neurotic does essentially is to maintain contact with reality. He or she knows what's normal in that situation. The symptoms can be very complex. They're often interwoven with each other, but DSM-4 identifies 7 major types of anxiety-based disorders, and we're going to spend a little time looking at each of those. And so in essence, what we're left with is a rather interesting controversy, and that is Freud's overall view of neurosis was attacked as too theoretical. And that's part of the reason that it ended up being bounced out of the DSM. And so now it's viewed as, Freud's view was simply viewed as referring only to internal, unobservable states, which made people uncomfortable. And so the DSM-4 and beyond actually pursues a theoretically neutral course. That is, it abandons the term neurosis entirely. As I said, when you get to DSM-4, neurosis is gone. It describes rather specific symptoms, specific syndromes. Anxiety disorder, somatoform disorder, dissociative disorder are among those. And the net result is that psychoanalysts are in an uproar, because in some ways neurosis was the crowning achievement of psychoanalytic theory. I mean, it summarized his whole model of anxiety-based disorders. And the change, psychoanalysts' view, was really a broad attack on their fundamental ideological tenets of psychoanalysis. But there are many disorders in this grouping that we're about to look at here that are fueled more or less directly by anxiety, and it shows up in a lot of different ways in our everyday life. One of them is the example of, or the occurrence of, what's called panic disorder. An example of panic, or panic disorder itself, is defined as you see here. excuse me, they're repeated attacks of overwhelming anxiety, usually appearing suddenly and unexpectedly. You don't expect it when you have a panic disorder, and the disturbance then is characterized by the occurrence of one or more unexpected, what are called panic attacks. Okay, it's not triggered by persons or by someone being the focus of someone else's attention. It's oftentimes more indirect than that. And interestingly, as a feature of diagnosis, it has to be experienced at least 4 times in a 4-week period in order to be considered a true example of a panic disorder manifested by a panic attack. And that panic attack has a number of different features that are involved in the classic panic attack. One of them is shortness of breath. Another one is palpitations, dizziness, a fear of dying, or a fear of going crazy. Any of those are symptoms of what people will experience when they're in the midst of a panic attack. It's not usually set off by immediately identifiable environmental stimuli, so my image of somebody in an elevator was not quite correct in that sense, but it often relates to the long-term loss of a significant relationship of one sort or another. The attacks usually subside in just a few minutes when someone experiences a true panic attack. But when they're in the middle of experiencing such a panic attack, simply assuring them that they're going to be all right, you'll be okay, is of no help at all in getting them through it. I mean, they're right in the middle of a mental, serious problem, a disabling problem in that case, and simply patting them on the shoulders or putting your arm around them isn't going to help in that particular situation. Another example, one that I mentioned here a minute ago, is agoraphobia, which is essentially being caught where the escape would be physically or psychologically difficult, as you can see in the definition there. That's yet another form of a phobia that may take place in a given situation. Interestingly enough, I had an aunt some years ago who, the last time I remember seeing her, I was in about, I'm going to guess maybe kindergarten or first grade, because she came out to a field where my mother and sister and I were playing. My sister and I were playing in the snow, and I remember meeting her that day in that situation. In my entire life, that's the last time I remember meeting that person, and she only died about 2-3 years ago in her 80s. Somewhere. And it was interesting that through the course of the years, I asked about, can we go visit him, because we were close to New Hampshire, which is where she lived. And there was always a reason why we couldn't quite get there to see her at the time. And when we did eventually get to see my uncle, perfectly nice, acceptable relative, we always saw him alone. He would not invite us to his house, but rather he would meet us at a restaurant nearby. And as I looked at it later, I began to realize that what we were really dealing with was what she had was agoraphobia. And the love relationship between that aunt and uncle was unusual in the sense that he defended her. He essentially supported the fact that she needed her privacy and just was not comfortable receiving us for guests that particular day. But her entire life was built around that. And it was interesting, depressing in a way, that about a year before her ultimate death, and perfectly natural causes for that, but about a year before her death, it had been arranged that, in fact, we were going to get together for the first time, me and my aunt and uncle, in the situation. It never actually unfolded. I wasn't able to analyze why that actually happened, but the steps were in sequence to actually have met her. But I'll bet you, dollars to donuts, never read a file on it. I don't know that she was ever under therapy, but I'll bet you it was simply agoraphobia, and the effect of that was that it gradually cut down on the arena where she was happy. Clearly, when I was in elementary school, she was comfortable being out in the open and interacting with people. That worked. But it gradually got to the point where she stayed on the farm that they had up in New Hampshire, Massachusetts, I guess, western part of west of Boston. And eventually it got down to the point where she stayed in the house, and eventually, I would bet, selected rooms in the house, and certainly at no time after she got in the house was anybody ever welcome to come visit her. So it's a life-encompassing kind of disorder when it does occur. There are some other phobias that also have attracted attention over the years in their unusualness, one of which is essentially an obsessive-compulsive disorder as one example of that, and that's where we define an obsession as simply a persistent preoccupation with something, typically an idea or a feeling. And the reason it's linked with compulsion is because a compulsion is defined as an irresistible impulse. Okay, it's experienced as an urge to engage in senseless kind of rituals and so forth and so on. This disorder may involve either or both of these particular problems. In one case, you're worried about the action, that's the obsession, and in the other case, you're actually involved in the action, that's the compulsion. So the obsession is mentally worrying about it, the compulsion is actually engaged in the behavior that you're fearful of in that situation. Now we shift into another group of disorders, and these are what are called the somatoform disorders, which in general are defined as simply physical ailments that have no authentic organic basis. And they're due essentially purely to psychological factors, and they take a number of different predictable but interesting forms. The bottom line for all of these is that it involves people who are preoccupied with their state of health in a given situation. Several different examples could be cited. One of them is what's called somatization disorders. This is any or multiple different examples of where some 35 different physical complaints may be cited by somatoform disordered people, and they will typically have a long, complicated history of treatment by doctors to whom they go. That is, the normal response here is not to go to a psychologist, it's to go to an MD. And so with a somatoform disorder, they will have a great big fat file from the doctor's office listing each of the different attempts that has been made to correct whatever symptom is being presented in a given situation. In many instances, those symptoms are unobservable. It's nothing you can put a stethoscope on or anything else and detect directly, but I feel, and the symptom is described there. Another way that we often will label it on the street is essentially hypochondriasis. And that is essentially, it's a multiplicity of complaints about a possible physical illness. So we define hypochondriasis as essentially, whoops, I thought I had one there and I don't. So let me back up a second so as not to confuse you. But that is essentially, it's an excessive preoccupation with health concerns. It includes incessant worry about developing physical illnesses. So these symptoms are kind of held short of actually causing difficulties. But a hypochondriac is constantly worried, oh, I've got a cold, carrying, Kleenex and blowing their nose all the time and so forth and so on. They're often disappointed if the symptoms if no symptoms are found, and that will often result in a hypochondriac saying to his or her doctor, I'm going to go get another opinion. Okay, it's your fault. I mean, the symptoms are here, I can experience them. And if the doctor is not able to, it gets rationalized to the point where the patient will simply assume quite convincedly in their own head that well, it's a doctor error. So we'll just go get another opinion. That's the life of a hypochondriac, taking those symptoms from doctor to doctor to doctor to find somebody to actually treat them in that situation. And the next one, the one that I popped on the screen here earlier, is what's called somatoform pain disorders. It can result in reports of severe and lasting pain in the back, in the leg, you name it. For either of those, there's no basis that can be found. There's no physical basis that's found for this kind of a thing. The symptoms are far in excess of what you would expect from what is found. If anything is found in the situation, in the body of the person, the symptoms that are being described, the pain that is being described, are way in excess of what can be warranted by what you find in the physical measures of the body itself. Another one, more complex here, is what's called a conversion disorder. And in this case, in its earlier existence, back in the time of Freud's heyday, this would have been referred to as hysteria. That was a name that was often applied to this particular kind of disorder. And in this case, what you've got, a conversion disorder, is simply a significant loss of physical function with no apparent organic physical basis. The symptoms can involve loss of control without any underlying organic pathology, arms that can't be used, hands that won't function properly, and so forth. Symptoms usually appear in a single organ system. I mean, it's interesting how specifically these things can be tied to particular body disorders, but they may be sensory, they may be motor, they may be visceral disturbances of various types that are constantly being reported. One classic example of that is what's called glove anesthesia, where essentially what happens is you lose all feeling in the moving part of my body here. You have literally, it's like you've got a glove on your hand that eliminates feeling from that whole area. The problem is, physiologically, there's no way for that to happen. because if you're aware at all of how the nerve system is distributed, there are two nerves. The sensory nerves for the hand are actually split. Part of them covers the last two fingers, and the other part covers the thumb and the first two fingers. So in fact, the sensing is split. If you had a nerve disorder at this point, you might lose either these two or these three. But there's no way you're going to lose this function unless you bizarrely have nerve blockage on very short notice in two different places in your body simultaneously. It just doesn't happen. And thus we come back to glove anesthesia as just one representation of what's called a conversion disorder. And finally then, I don't have a slide. I tried to get it and I was not able to get it developed in time here for today's lecture. But to show you an example of how severe conversion disorder can be, what one investigator did was to look at the number and the location of major surgical procedures in 50 hysterical patients, that is 50 people who were suffering conversion disorder, as contrasted with 50 control patients who came in with whatever kind of need for an operation. One of the ones that's being advertised right now is the what is it, the black or the brown procedure, whatever it is, where they put something up in your hand and wiggle it around and nerve function and so forth is restored. But in any case, they compared 50 normal healthy controls that, yeah, they needed an operation, so healthy is a little strange as a definition there, but 50 otherwise healthy control. The better way to say it is non-conversion disordered patients. Compare the number of complaints and the number of operations performed against a group where we had conversion disorder as a diagnostic label that could be applied. And what was found was that by weight, more than 3 times as many pounds of body parts were removed from those that were suffering the conversion disorder and resulting operation than for those that came in with an otherwise healthy body that had a particular problem that might have required the operation. So that the conversion, that is really a case of mind over matter. In that case, the conversion disorder is a mental disorder, and in fact it leads to being absolutely convinced that, gee, we've got to get this out, it's causing a problem. 3 times, more than 3 times as many body parts removed. Strange. Then let's look at another broad class of disorders, and those are what are called dissociative disorders. In this case, what you're doing essentially is escaping responsibility for one's personality, one's unacceptable behavior, by simply disassociating yourself from your personality. And the ways those are done are classic. It results in essentially a disruption of your identity. A severe repression is what's going on here. I'm thinking of Jekyll Hyde and the 3 Faces of Eve, which we'll talk about here in a minute. One of the types of dissociative disorder that we may have is what's called psychogenic amnesia and fugue. There are 2 different situations that are involved here. Amnesia, of course, is partial or total inability to recall or identify past personal experiences. And in that case, what it may involve is essentially a failure to store the information initially. That's one possibility, but explaining exactly why amnesia occurs is difficult. But in any case, psychogenic amnesia is essentially a failure to recall important personal information, and the loss is too extensive to be due to simply normal forgetting. I mean, any of us may be guilty of not being able to remember somebody's name whom we've met at a party previously or in an office situation or something. But psychogenic amnesia is the forgetting is way too extensive to be attributable simply to, or the lack of recall, way too extensive to be simply attributable to normal forgetting. And on the other hand, we can also have what is called a fugue reaction, F-U-G-U-E, and that is essentially a defense that is mounted by actual flight. The individual is not only amnesic, but they also wander away from home. They'll often assume a partial or even a completely new identity when they get away from the situation that they're trying to escape in that situation. I would go back and cite to you the example of the Cleveland radio announcer the radio announcer who left his home initially and moved to a different situation and had a career, a money-earning career set up and functioning when he was discovered by a friend from the original environment that he'd escaped from. And finally then there's another form of disorder that has had several different labels applied to it. This used to be called multiple personality disorder, and there's a reason why they backed away from it, and now it is called simply a dissociative identity disorder, or DID. It's a dissociative disorder, usually identified with an identifiable stressor of the participants. That is, there is something that is annoying the participants, in which the patient ends up, the participant ends up manifesting two or more complete systems of personality. They can switch from one to the other under given situations. Each has a distinct and well-developed emotional pattern and thought processes, and a unique and relatively stable personality. That is, when in the form of one of the personalities, the symptoms are consistent. That is, they won't, if a personality is left-handed, when you're in that personality, you will not pick up and eat with your right hand. That would be a violation of one of the elements of that personality, and people just don't do it. Dr. Jekyll and Mr. Hyde is a classic example, but there's a more recent one that is even more directly on target, and that is Joanne Woodward ended up winning an Academy Award for her depiction of a lady named Chris Sizemore in a movie at the time that was called Three Faces of Eve. And Eve, the subject of this story, had a long, interesting career. That is, I've read written descriptions of what she did. She was actually an invited guest of one of my classes here at the University of Houston about 10 years ago now. You'll never meet a more charming, as it turns out, totally reintegrated personality. She's about, probably by now, mid-60s, white-haired, silver-haired, very affable, a very pleasant person to interact with, and she can talk with complete dispatch about the conditions that she was subjected to, until she eventually found a therapist after about a 20-year hunt to do what she called reintegrate herself. And her primary role now is campaigning for mental health support. That is, she thinks it was unnecessary for her to have gone through all the difficulties she went through before finally finding somebody to help herself in that situation. But in the initial event, the initial situation that she developed into, she started out as Eve White, who was industrious, a little bit dull, but she was admired as an individual, but relatively passive in personality style. When that person became pressed, she ended up morphing into the person she called Eve Black. That person was rowdy, funny, irreverent, and essentially impulsive, unthinking in her behaviors in that situation. So it was really a very significant shift from somebody who was admired but passive into somebody who was rowdy and unthinking. It was a significant personality shift. And the result, when either of those got in trouble, was that she could morph into what became known as Jane. Jane had a very positive attitude, a vivid personality in and of herself, and no memory at all of either Eve White or Eve Black. So essentially she had Eve White and Eve Black who could actually talk to each other. That is, the therapist could talk to one of those and ask her to morph into the other kind of personality. And she would, look a little askance at the therapist as she was being encouraged to do that, and then could morph into and would become the other person and talk about what Eve White had just said when she is now Eve Black and so forth. And yet when she morphed into Jane, she lost the ability to communicate, to talk about Eve White and Eve Black. She eventually went through over 20 different, some 21 or 22 different personality styles before ultimately collapsing everything into the Chris Sizemore, which is her actual name. And she, many years later, this actually was achieved in 1974, the book that she wrote, which is called Three Faces of Eve, came out in 1974, and I think I'm Eve eventually came out in the early 1990s. And she wrote a book where she outed herself. She acknowledged that she was, in fact, the Eve of the movie called Three Faces of Eve, and her actual name was Chris Sizemore. And it was revealed then in 1975 that she had actually divorced, remarried, and she had experienced a number of more personalities. She lived in a suburb of Washington and eventually moved to Florida, where she now is, living a perfectly happy, normal life. It has been said, not specifically of Eve Sizemore, but rather that a person with a neurotic disorder builds castles in the sky, but a person with a psychosis actually lives in castles in the sky. And it should be pointed out, it's a psychiatrist that collects the rent, but we won't get into that. Specifically, what is involved is one other type of personality disorder that I do want to spend a little time on, and that is psychotic disorder, psychoses specifically. And that is essentially, it's a, whoops, oh, I blew past that. I didn't realize I had both of them integrated there. Let me spend some more time on that, because I wanted to point out two things here, and that is that it's basically a group of different types of disorders, some of which we'll talk about here. And they really involve extensive and severe psychological disintegration. It involves a disruption of all forms of adaptation and a loss of contact with reality. One of the key differences, well, I'll get to that in a few minutes, so I won't talk about it now. But the diagnosis of a psychotic disorder, of somebody with a psychosis, can be pretty difficult, because first of all, there's a variety of different typical symptoms that may be presenting. There can be a combination of disorders that can occur in this, and therefore many different symptoms that may show up. And there is difficulty. The whole thing is based in a human who may be quite difficult to interact with, either because they're simply not maintaining any contact with reality, or they don't acknowledge your existence in the world, and in their world they certainly don't. That can get to be difficult. But the psychoses are really divisible in the DSM into two broad categories that we'll spend a little time with, one of which is mood disorders, and the other of which is schizophrenic disorders, which are different in a variety of ways. So if we look first of all at the mood disorders, we can define it essentially as a disturbance of feeling or mood with resulting behavioral or thought abnormalities. And the features in this kind of a situation include things like exaggerated mood. Somebody with this kind of an affective disorder may be either elated or depressed, significantly so in either case. It's not obviously related to external events. There's no immediate demonstrable external cause of the disorder here, and it can actually disrupt all physical, perceptual, social, or thought processes depending on which subset of normal human skills is interrupted. So it can be very disruptive when a mood disorder strikes. There's a difficulty in defining and classifying this as also involving depression, but there are a number of different major features that can show up in here. It is a mood disturbance. It may include a wish to die, self-denunciation, feelings of guilt or a need for punishment, and it's really second only to schizophrenia as a basis for admission to mental hospitals, the basis for people being admitted to mental hospitals. There are two major and several less frequent, less important variations that can also occur in this particular type of disorders. And so the problems that we have are basically those of really being able to specifically identify the unique combination of symptoms that somebody is manifesting when subject to this particular kind of disorder. But one of the elements that does clearly show up there is the what's called unipolar disorder, typically featuring only depression. I'll come back and talk about why in a few minutes here, but basically what's involved there is someone who's got a unipolar disorder of the depressive type is really showing persistent feelings of sadness and despair and a loss of interest in previous sources of pleasure. Things that used to give one pleasure just are ignored. You're no longer interested in it. It's an exaggeration. If you encounter somebody in this particular state, what you experience them is as if they're in an exaggerated state of normal sadness. But they simply take the high points and emphasize them in that situation. Changes inside are emotional. It increases the lack of involvement with other people. That is, you have less involvement with other people. Motivational factors can be impacted. You seek an environment in which it can be quiet. That is, they really desire to go curl up in the corner with themselves. There's a loss of initiative. They will tend to show active withdrawal in a situation. There are physical and behavioral problems that can show up. They can be very passive. They literally will be walked stooping over. No interest in sex. They have no appetite. So it's a physical and behavioral withdrawal from the normal activities that we participate in. Cognitive factors would include a very negative view of oneself and of others, of the world, of the future, of everything. And the net result is that suicide may result in this particular situation. So this can be a markedly serious disorder in this particular point. I guess there's no time in the comments here where I'm going to make a particular combination here, but a particular comment, but I should make one, and that is that depression of this type is more serious than the depression we were discussing earlier when it's part of an anxiety-driven neurotic disorder, as it used to be called. The anxiety-driven disorder is treatable and is more immediately fixable than is a psychotic type of depression of any type. Suicide is a more common result in this situation if you're not watching that person carefully. It's a very common disorder. 7% of the population endures such a disorder at some time during their life, so it is to a certain extent environmentally driven. The second possibility, the other type of mood disorder that we can also talk about, because the unipolar is typically depressive only, and the other type is the bipolar disorder, also referred to as essentially a manic depressive. In this case, there may be extreme swings of mood from mania, which is essentially, it's a high energy, very optimistic, personal worth of me is immediate and obvious to everybody. So the image is just outwardly very positive, abnormally so. That is, you begin to kind of back off and think the person is really touting their own case a little bit more strenuously than they really ought to be. The difficulty is the reason that it seems that way is simply because it's not reality oriented. The person can think of no wrongs that they're not capable of fixing. They live in what has sometimes been described as the world of Pangloss. It's a perfect world, and if there's any problem, it's fixable. We can get around that. We can fix it up. No particular difficulty, and that in turn leads to some rather interesting, in manic depressive states, some rather interesting cycles that may occur. You're cycling between mania and depression, extremes in both instances. And with the mood swings that you get in this type of disorder, one of the classic types is described as simply circular. You could almost set your watch by the cycling from an extremely manic state into an extremely depressed state. And the shift is, I realized as I looked at that visual, that it really is perhaps more gentle than what it should really be depicting. Maybe we should have spikes there headed each direction. But the shift can be quite rapid from extreme happiness to extreme sadness, and just in the drop of a hat almost. Another way in which this will happen is alternative periodic swings. You may have periods of normality separated by periods of mania and or periods of depression. But again, the systematicness of it, the regularity with which it occurs tends to be almost clock-like. And then finally, there is also a pattern where you may simply cycle from depressed to an extended period of mania, and no particular prediction as to when somebody will come out of a particular cycle, whether manic or depressive, but there are very clearly long stretches where you're in one or the other abnormal state. It creates essentially a very rich opportunity for research as to the causative factors, but we know, for instance, among other things that's been discovered, is that it is inherited. So if you look at identical twins, if one of them is a manic depressive, about 2/3 of the other twins will also be manic depressive. 67% of identical twins share manic depression among them. Fraternal twins, on the other hand, only 15% of them show up. If one is manic depressive, only about 15% of their brother or sister will be manic depressive. Some of that may be caused by, it may be acknowledging that there is an environmental contributor to this, but the evidence seems pretty clear that it's primarily a genetically carried disorder. The predisposition toward genetics is quite clear in this case. Some mood disorders have a neurochemical basis. We know that amounts of norepinephrine and serotonin are correlated with mood disorders and causing of them. They're correlated with mood disorders when they occur. But then if neurotransmitter availability signals mood disorders, what determines neurotransmitter availability? That then becomes the issue. So there are ways to study it, but the evidence does seem pretty clear there's a genetic basis here. If we look at another general class here, and that is the schizophrenias, literally schizophrenia means split mind, but that was not what Eugen Bleuler had in mind when he originally coined the term back in 1911. It refers to a fragmentation of thought processes. That is what you see in schizophrenia. It's difficult to define, and the best current strategy is to view it essentially as a collection of disorders sharing a number of symptoms in common. It involves about 25% of all hospital admissions. Okay, and somewhere between 1 and 1.5% of our the population as a whole may suffer schizophrenic disorders during the course of a lifetime. So if we define it, we'll simply define schizophrenia as a psychosis including several forms, all of which share a number of symptoms in common. The onset can be very rapid, or it can be slow and quite gradual, depending on the particular state. There is progressive deterioration that is often observed in this particular disorder. Richard Swin at the University of, I guess it's Colorado State. He's in Colorado, state institution. And back in the mid-70s, he published a very interesting paper in which what he did was kind of look across all instances of schizophrenic disorder. And he came up with what he identified as 7 symptoms, common factors that you were most likely to see in instances of schizophrenia. One of these was simply withdrawal or seclusiveness, a tendency to back away from people into one's own private world. There was secondly a disturbance of emotions where they were either shallow or inappropriate to the situation in which they were being expressed. You know, somebody who goes to a funeral and bursts out laughing in the middle of the service would be an example of an emotional disturbance that is quite inappropriate at the situation where it's being, in the situation where it's being expressed. A third is the existence of what's called autistic thinking. It is essentially a retreat into a private fantasy world. I have seen films of a youngster, a child, who was autistic, and it's just spooky to watch it happen. Because in essence they are literally in their own, not it happened, but to watch the behavior that results in that situation, they're literally in their own world. They are talking to themselves. As near as you can tell, they're getting answers from various sources, but it's a retreat into one's own private cognitive world when you talk about autism. There may be various kinds of bizarre behavior that a schizophrenic will exhibit. There can be related sensory disturbances that they report experiencing. There can be various kinds of delusions, either of persecution or of grandeur, that may occur in this kind of a situation, and there can be a disturbance of speech and thought. Classic schizophrenic language is quite consistent, predictable in the way in which it deviates from normal language, and in fact people have done studies of specific schizophrenic language. These conditions and the condition itself, these symptoms I should say, and the condition itself are really aggravated by 2 things. One is the early onset, because it strikes people normally in their late 20s, early 30s. 30 is kind of the target year. And the other is that there's a relatively poor prognosis of recovery from this kind of a situation. A couple of different types I would show for you. One of which is what's called paranoid schizophrenia. The onset there is between 25 and 40. It's less severe than the catatonic and the disorganized that we'll talk about here in a minute, but I can show you, you will recognize or may not recognize this person, but this is Sirhan B. Sirhan, who was the assassin of Robert Kennedy. And he was ultimately diagnosed as a classic case of a paranoid schizophrenic, often heard to mumble to nobody in particular, "I am the savior of my people," and that's a classic example of the paranoid tendency there. That is both the positive and the negative. Persecution and grandeur is the word I'm looking for, and that is that one phrase, if you think about it, really wraps up both of them. "I am the savior" is simply a delusion of grandeur. You know that whatever he's capable of, he's going to save. And then the idea that his people, not otherwise identified, need to be saved is clearly indicating that they're suffering some kind of bad pressure on them at the moment. So the delusion of persecution is there, and the person of grandeur, "I can save you" kind of thing going on. It's illogical. There may be hallucinations going on. There may be, interestingly enough, intellectualization. And some have argued that if you grant a paranoid schizophrenic's first argument, you're going to lose. If you grant the first assumption, they are skilled enough with language and defending their particular position that you're going to end up losing the discussion. Another one we can talk about fairly quickly here is catatonic schizophrenia, where there are motor disturbances, deficits, essentially a stupor or excessive agitation, where somebody may actually hold up one position for hours in this kind of a situation, and they will exhibit waxy flexibility. You may move them into another position, but they can stand there with their hand hanging out for 30 minutes, and you know, what you and I would relax in 10 seconds will take 30 minutes in this case. We'll pick it up next lecture.